Good afternoon, everybody. I would like to share this afternoon my experience concerning the dynamic contrast enhanced ultrasonography for the early evaluation of anti-angiogenic treatments. And this is a validation of biomarker. So why do we need tumor functional evaluation? Because with the new anti-angiogenic treatments, we have often the necrotic area after 6 months or 9 months, and this is the case of this patient after 9 months of sorafenib. And the goal of the functional imaging is to try to quantify the modification inside of the tumor and to try to link this modification to the overall survival or to the progression-free survival. And this is a challenge of the functional imaging. And the main example currently is the renal cell carcinoma. In this slide, we have more than 6 new drugs, but currently we don't have biomarker in order to select earlier the best treatment. So the challenge is to try to select a biomarker. And remember, on this talk, we are speaking about predictive biomarkers. So we compare baseline, so before treatments, and after treatments. And if we are speaking about biomarker, remember, we have the Oxford guidelines, so we need to validate in preclinical studies. After, we need to perform several monocentric studies, and we need to finish for the FDA with a multicentric study. And if we try to benchmark the CMRI and this US. Currently, we don't have data for multicentric study in this MRI. We have more than 100 monocentric study with this MRI, including more than 1,000 patients. But for the DCUS, we have 1 multicentric study for the validation. So the key point for the functional imaging is the standardization. And remember, with this technology, and this is the same for this MRI or this US or CT perfusion, we are able to calculate different parameters. We are able to calculate the blood flow. This is the perfusion of the tumor. The blood volume. The blood volume, this is a percentage of the vessels in the total tumor. And the mean transit time. This is the time during the wash-in and the wash-out for the contrast media. So with the DCUS, we have the best temporal resolution. Remember, we are able to record 4 frames per second during 3 minutes. So we stay on the same plane, and we record the washing, and now the washout, and during 3 minutes. And we record automatically 3 minutes of this kind of data in order to perform the quantification. So if we try to link the blood volume, the blood flow, and the mean transit time, remember, the blood volume, so this is a percentage of the vessels in the total volume. The blood volume are linked to the peak intensity or the integration under the curve, under the total curve, or under the wash-in or the wash-out. If you are interested to evaluate the blood flow, which perfects the tumor, the blood flow is linked to the time to peak or the slope during the wash-in. So the last point for the quantification, remember, and this is the same case for the CT perfusion or DCMRI, if you perform the quantification, you need to use the raw linear data. And now this is a good news. All companies, GE, Philips, Siemens, Toshiba, or Supersonic Imaging, are able to provide this type of data. So this is no research now. You are able in routing to buy a machine with the raw data. So in order to save time, we try to standardize. So now we are working on the workflow. So it takes few seconds for the quantification. You determine your regions of interest, and we are able to record wash in and wash out and we have 7 parameters related to the blood flow, the blood volume, and the mean transit time. So the last point, if you are working on the liver, you need to perform the tracking. So 5 years ago, we have performed manual tracking, but now all companies are able to provide software. And in this case, the software is able to perform the automatic tracking. So if you choose the best plan according to the respiration of the patient, you are able in few seconds to perform the quantification on the liver. So concerning the good way for the quantification, we wrote the first guideline for the quantification with colleagues from Italian and Dutch and also UK. We propose in Europe to work with bolus injection to perform the quantification from the raw linear data of or adapted software, and also to record 3 minutes, in particular for metastasis. If you are working on hepatocellular carcinoma, sometimes the washout is not finished at 3 minutes, so we propose to record during 5 minutes. So concerning the validation of biomarkers, so we decide, according to the Oxford guidelines, to perform several studies with different types of tumors, so hepatocellular carcinoma, renal cell carcinoma, cyst or phase 1 study, or also HCC, with different types of anti-angiogenic drugs. So this is bevacizumab, sunitinib, mazatinib, sorafenib. And with 5 studies, including more than 136 patients, we evaluate the 7 parameters. And we understand that only one parameter is always linked to the RECIST response. This is the area under the curve. This is the integration during the wash-in and the wash-out during the 3 minutes. And this parameter is always significantly linked to the RECIST response. This is an example of the renal cell carcinoma with metastasis. So this is on the CT scan at baseline on B mode. So this is before start treatment. So this is a very vascularized lesion. We are starting sunitinib, and we evaluate the patient after 2 weeks. And according to the RECIST evaluation, we have a stable disease according to the largest diameters. And when we inject the sonoview in bolus, we understand immediately we have a strong decrease, a dramatic decrease of the vascularization with a very small area with the vessels. And in fact, it was a very good responder, a partial responder, with a partial response at 3 months and 6 months. And when we compare the time intensity curve, so this is at baseline, and after 2 weeks, after cycle 4, cycle 6, and cycle 8. So with Professor Villegrain, we try to compare CT perfusion and DCUS at 1 month on hepatocellular carcinoma. And when we compare both examination, only the DCUS was able to predict the response at 1 month. So let's go to the validation. Remember, we need to perform the multicentric study, and we performed this study with the Ministry of Health. So the goal was to try to standardize the good methodology, the raw linear data, the quantification, to try to select the best parameter, probably eye under the curve. Remember, we have 5 monocentric studies, but also the challenge was to determine which is the best cutoff, a decrease of 20%, 30 or 40%, which is the best timing, and if we are able to link this biomarker to the overall survival. And remember, for the FDA, this is the best endpoint for the validation of biomarkers. So we decide to include all patients with anti-angiogenic drugs, so patients with metastasis from breast cancer, melanoma, colon cancer, cyst, renal cell carcinoma, but also primary tumor. So this is HCC treated with sorafenib. We standardize the acquisition, baseline, 1 week, 2 weeks, 1 month, 2 months, and we perform the RECIST evaluation. Remember, this is an international rule for the evaluation in oncology, so a CT scan every 2 months. We standardize the methodology, so we have the fixed setting for abdominal probes or superficial probes. And this methodology was published in Investigative Radiology in order to give a quality score for each examination from 0 to 5. So we include more than 500 patients. The median follow-up was 20 months. We performed more than 2,000 examinations and 1,700 CT scans. Concerning the histological type, it was not a surprise. We have a lot of renal cell carcinoma because remember, we have more than 6 drugs, so the oncologists want to use the functional imaging. We have more than 100 HCC because we have the sorafenib, and after we have more than 50 colon cancer, breast cancer, melanoma, and cyst. Remember the drug, anti-angiogenic drug, which gave the necrotic area. This is sorafenib, bevacizumab, sunitinib, and imatinib. Concerning the target, we have half patient with lesion in the liver, but half outside. So this is lymph node, this is peritoneal lesion or kidney lesion. Concerning the validation of scientific results, so when we compare 7 parameters at baseline, so this is a prognostic factor, we have no results, and we have the validation at 1 month. And our goal was to validate the area under the curve. And we have a significant results at 1 month with area under the curve. So the next step was to try to select which is the cutoff. Using the ROC curve, the statistician determined the best cutoff, and the best cutoff was a decrease of 40% of area under the curve at 1 month. When we use this biomarker, we have a significant correlation with the progression-free survival, and you could see that the follow-up is 3 years. And when we move to the correlation with overall survival, for the first time, in multicentric study, we have a correlation with overall survival, a significant correlation with a decrease of 40%. So the next step was to understand if we are able to use this biomarker in all types of tumors and all treatments, according to the tumor and the treatment. And in order to answer to this question, when we check this graph, if you don't have significant heterogeneity with this test, it means that you are able to use this biomarker for all drugs. And this is the same case for the tumors. As we don't have significant heterogeneity, it means that we are able to use a decrease of 40% at 1 month for renal cell carcinoma, HCC, colon cancer, breast cancer, and cyst. So we published on the second article in Investigative Radiology in 2014. So I would like to show you one example. This is a woman with anti-angiogenic drugs. This is a lesion in segment 5, so on B mode and before treatment with a new quantification. And after 1 month, so 4 weeks, we have a strong decrease with a decrease of quantification. So the last point is the validation. So with 75 experts, we try to give a standard for the biomarker for the CT, DSMRI, PET, and ultrasound, and we published the table on the Nature Review Clinical Oncology. And on this paper, all authors recognize that area under the curve is a biomarker because we have a correlation with the progression-free survival and overall survival. And if you compare with the CT and MR and using catrons, they propose this technology with single center studies. So I would like to stress you the last point. I think this technique is very useful if you are working in oncology center, and in particular in phase 1. Phase 1 is the first clinical trial when we are trying new drugs, often with different histological types, and often with these techniques we are able to understand very quickly if the drug is efficient, for example, in melanoma or in a colon cancer, and you could help the oncologist and the company to select the best drug. So in my institution, in a lot of anti-angiogenic clinical trials, but now also in immunotherapy, we evaluate very earlier the patient with this AUS. And in fact, if you are using this biomarker, you are able to select a bad responder with a PFS about 3 months, comparing the good responder with a PFS about 1 year. And this is an example that we present in Resena with a comparison with MR and this AUS. So this is a sarcoma treated with a nanoparticle combining with radiotherapy. So this is a necrotic area here, if you compare before treatments. And after 1 month, we have an increase of the necrotic area. This is just before surgery, so we have only 20% of the contrast uptake when we inject the contrast media, the synovium in bolus. You could see only this part. So this is here, and the other, this is a total necrotic area. And in fact, this is the MR just before surgery with the same large necrotic area and only this vascularized tissue. And in fact, at histological analysis, we have exactly 20% of variable cells and 30% of necrotic area. So this indication was added in the European guidelines published in 2011, and I think now we have soon a good news from Paul Sidu. And in this publication, this indication had the label A1B, and if we want the maximum label, we need to have 2 multicentric studies. So currently in France, we are starting another study in colon cancer treated with VEGF trap with 6 centers, and probably after we have the maximal level with 2 multicentric studies. This indication was also added in international guidelines, and remember, this is good news, the contrast was approved in the United States, so for us this is very good to try to push this indication for all patients in the world. So I would like to conclude. So now the dynamic contrast enhanced ultrasound is the standardized technique. Remember, in Europe, we decide to work on the raw linear data and bolus injection. You are able to evaluate automatically blood volume, blood flow, and the mean transit time. Remember, the biomarker validated is the area under the curve at 1 month, and this is a decrease of 40% at 1 month. And with these biomarkers, you have a correlation to the overall survival and progression-free survival. And this biomarker was published in Investigative Radiology and now recognized in the Nature Review Clinical Oncology. And I would like to stress you, just 3 months ago, my colleague in research published in UMB a methodology in order to try to perform the calibration between different machines from GE, Toshiba, Philips, supersonic imaging, in order to reproduce the quantification with a stick study to perform multicentric study with all companies. And currently we are working on this with Chiba in Arizona. So thank you very much. So now I am very happy to try to answer to question.
Okay, thank you, Natalie, for a very comprehensive and detailed review of the subject, and I appreciate that you've been working on this for many, many years now. I'm going to ask just one question before we move on to the next speaker. You say that the software and everything is ready for people to use. Is it, if someone has experience in contrast enhanced ultrasound, how easy is it to pick up this software and start using it in practice?
So the software, so my experience is when I try to teach young radiologists to perform the contrast, and in particular the quantification, in the first, with the first patient, the first 10 patients, I learned to radiologists to perform quantification just after to perform the acquisition. Before, the goal is to try to understand which is the best acquisition. You understand that we need to follow the motion of the liver of the patient. So when you try to learn to perform the quantification, and after the first day, the young radiologists are able to perform the quantification. It's very easy. So I think when you start contrast for evaluation of treatment, you need to teach immediately also to perform the quantification on the workstation, because after the acquisition will be better. And for example, in the STIC study, we performed 2,000 examinations and we delayed only 3% of the examination. This is a very few excluded examination. And we understand, and it was published in the first paper for the standardization. We understand that the first 10 examinations, this is a training, okay? But when the radiologist performs more than 60 examinations, he is able to have a very high quality, 3 to 5. So I think the curve for the training is easy to obtain with a high quality.
Thank you, Natalie. This is very encouraging for people to take this up, and thank you very much for your lecture. I just want to remind all the delegates here that you have the facility to ask questions online, and I'll put this to the lecturers.